Okay, so pursuing medicine is easy. I think in my family, my father was a doctor, so I think when I was small, allegedly, I already wanted to be a doctor because I would climb on his chair, put his stethoscope around my neck, and sort of see patients, quote unquote. But and I think there are about 11 doctors in my family at last count, so it's not a new profession. For health services research, actually that came about later. So when I did my PhD, it was actually in translational science. So I did my PhD was in resistance mechanisms in multiple myeloma, and the reason why I joined NUH was because of Professor Xiong Wiju, because he's a myeloma person. But after a while, I realized that actually the translational work, although it's important, it doesn't translate to sort of immediate results, and you don't see the immediate results to your patients that you're seeing on a day-to-day basis. So health services research was something that allowed me to sort of see the change almost, kind of as I implement it for the patients, and that was what drew me to HSR in the first, kind of eventually.
Okay. Thank you.
I think, as I mentioned, I see a lot of older patients. So because of my two disease subspecialties, so I'm a leukemia as well as a myeloma doctor. And just by nature of the disease, we see a lot more elderly patients. So people who are like in the 60s, 70s. And I think in the past, when treatment options were more limited, most of the time it was like, either they can go for transplant or intensive chemo, or it's palliation. But now with the advent of newer therapies, kind of more treatments availability, it becomes a decision of, do we keep trying, beyond sort of third line, fourth line, and can the patient tolerate the treatment? And I think that having these treatment options available, sometimes the decision is very difficult for the doctors to make because we're not sure how fit patients are, how well they're able to tolerate chemotherapy. And that's what initially got me interested in HSR, because I saw a gap where our elderly patients were not being properly assessed with geriatric assessment. So we have geriatricians and then we have oncologists, and there was a kind of a divide between the two. And so what I hope is my research was actually to bridge that gap, where we don't behave like a geriatrician, but we sort of take some of their knowledge and apply it to our oncology population to see how we can help stratify the patients, optimize them for their chemotherapy, and also to sort of build resilience in them. And using these strategies, we hope that they can tolerate chemo better, less toxicity, and obviously have a better quality of life. Not necessarily quantity of life, but quality of life while they're undergoing treatment.
Okay, thank you.
So I think what's most rewarding, as I said, the difference between sort of translational science and implementation science is you can see the effect a little bit quicker. So we're seeing that now. So I've been on this HSR journey since about COVID time 2020. In that time, we've already implemented, because it's health service research, we've already implemented a geriatric hematology program. We have already shown efficacy outcome where we have been able to demonstrate that despite sort of referring patients more to services, we're actually not costing the health payer as well as the government more money. And we've also shown survival benefit as well. So this is what within COVID to now is about 5 years. So we've actually been able to achieve that outcome. Whereas I think that when I was doing my PhD, I was treating mice, and I don't think the drug that I ever used to treat mice was still now not in the clinic yet. So I think that is what excites me about HSR. And what message I would like to provide. I think this research pathway is quite new. A lot of people don't really know much about it yet. And I think that a lot of times people think research is basic science, lab, treating mice, treating cell lines, etc. But there's actually a whole avenue of researchers that are more sort of intimate with the patient. There's more contact with the patient, and you get direct patient feedback as well. And I think this is something that might hopefully inspire a new generation of people who never thought that this was research, quote unquote research as well, and they can actually do as well to help their future. Like if they're interested, they can actually join and help patients in the future.
Oh, yeah. Thank you.
Okay.